Portland from University of Oregon. So it's really great to have them both here. Both are experts in cutaneous lymphoma, so they can pretty much answer any questions, or, yeah, I know they can. And we're gonna just have run the mic around so people have questions, and this is your time to pick the brains of our experts. And this is all to get the questions that you didn't get answered maybe yesterday, or new questions that came up. And so that's what we're gonna do over lunch, and please continue to eat, but hopefully we'll have some brave people. I know we had one question already that was presented by somebody, so we'll start there while you all can start formulating your questions and your thoughts. I'm going to turn it over to Tasha. We are going to use the mic, so when you ask your questions, we ask that you use the microphone so everybody can hear your question. And we'll start with that one. Tasha, I'll let you.
Thanks, Susan. So the first question reads, I received the shingles vaccine years ago. Since they have a new vaccine and say older adults should have 2 shots of the vaccine, is it recommended I do so?
Yes, is the answer. So the old shingles vaccine, it was about 78% effective. The new one's more like 96, 97% effective. And the good thing for this group is that the new one is not a live vaccine, so that it's safe. And there are 2 of them, and they're separated by several months. 2 of the same shot, like a booster and an original shot.
I know MF is not contagious, but should I be donating blood? Is that okay?
No, you won't be allowed to donate blood. No one with a diagnosis of cancer can donate blood.
We have a question about biopsies and the process, and we have one gal that's having a difficult time getting her diagnosis, and I have one guy in my group that's at 26 biopsies, so he finally got his. I was lucky I got mine on the first one, and I was explaining that, it's this process. They take the biopsy, they see something, they do staining, and then if they see something with the staining, it goes on to the PCR. Well, at the Portland conference, Dr. Shinohara talked about the high throughput method of managing biopsies. Could you talk a little bit about that?
Okay. This is a disease that is hard sometimes to see in the biopsies. So I think the average is 5 biopsies before something becomes diagnostic. The pathologists will often use these buzz terms called suspicious for, consistent with, and then diagnostic of. And that's just the changes that they see in the biopsy, in the certainty that this is mycosis fungoides and not one of the other more common inflammatory skin disorders. So it is uncommon to get a number of biopsies before something is, quote, diagnostic, and you have to put that in, and then what the pathologist gives us that information, and as clinicians we use that information and put it into the clinical context to see, does that still make sense with the way that the rash looks, the way that it behaves to treatment, and its clinical course. And so it isn't just a pathologic diagnosis. Sometimes it can be, but oftentimes it's a combination of multiple things. Then the dermatologist, and it's mostly the dermatologists that do the biopsies. I do a couple, but and it's if the rash changes in character, so instead of being, this little nice flat stuff and it starts getting a little more indurated, they will wonder, is this still the right diagnosis, or is it something different, or has that diagnosis changed? Is there some larger cells that are in the biopsy that would make them worried about transformation and things like that? So unfortunately, it does require a fair number of biopsies, and some people whose disease is very stable get very few. Some people whose disease fluctuates a bit will get more, and depends on how much inflammatory or obvious the biopsies are, will also dictate how many. The new thing that we're trying to do is with these newer techniques of looking at what we call the expression array, looking at either the mutations that are in these biopsies or what kinds of genes they express through these high throughput sequencing algorithms, there may be a more definitive way to make the diagnosis rather than looking at what it looks like under the microscope or what kinds of proteins they express on a limited immunohistochemistry analysis, but looking at a more detailed or finer way to discriminate. That's very much still, I would say, in the investigational stage where I think people would be a little hesitant to make treatment decisions based on that, but we're working toward that.
I think the other thing to realize is that there are conditions under which you can optimize the biopsy results. So one of those would be that the person has not utilized any steroids, either on their skin or taken by mouth for at least 4 to 6 weeks before the biopsy, that the biopsy be taken from the thickest area. And finally, that it goes to a pathologist that's very used to looking at mycosis fungoides. Because often the changes are quite subtle. And a general dermatopathologist may not feel comfortable making a call that it's mycosis fungoides, whereas someone who sees many, 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 many cases per week would feel much more comfortable.
I just want to make one clarification. If you stop treatment, you don't need to stop all areas. Just leave one area of the body that you're going to target and say, I want to get that area biopsied. You can use steroids on the rest of everything else. You don't have rip-roaring disease. We don't need to see everything flaring, just one area that helps with the biopsy.
First of all, thank you both for being here, and Dr. Pinter-Brown, you're such a great supporter of all of us. I really appreciate your being available to us in so many different ways. I have a very specific question that came up in conversation this morning with others. I have recently been asked to do light therapy on my entire face because I had 2 patches, and was told where I get it done that it's fine if I just keep my eyes closed and don't use the goggles when I'm doing the face. It's for not even a minute. And someone said that they were worried about that. Another patient. Is it okay? Eye issues? I don't know.
I have had patients that have had to do that because they had eyelid lesions. I'm not a dermatologist. I'm not really trained in light therapy. I don't know if you feel any more comfortable, but in very certain cases, I think it's okay. But those cases don't come up all that often. But I think if somebody's trying to treat a lesion that would be covered by the goggles with light, then the goggles have to be removed and the person really has to keep their eyes shut.
Okay, but it's not where the goggles would be, so maybe use the goggles.
Yeah, if it's not where the goggles would be, then you can use the goggles. The only reason not to use the goggles is if the strap or the goggle itself is sitting over the lesion.
The downside of not using the goggles, they're worried about developing cataracts is probably the biggest concern, because a little bit of light gets through the eyelid and it will cause some crystallization in the lens, and so cataracts. If you already had lens replacements for cataracts for other reasons, then that concern is obviously a lot less and wouldn't be a problem.
We actually have a nurse practitioner who's here and does work with phototherapy. She's going to offer some additional insight.
With narrowband UVB therapy, as opposed to any UVA type therapy, the waves only penetrate as deep as the epidermis, and so for narrowband UVB and using the light booth, it is okay to just close the eyes. But make sure that the eyes are closed before the lights come on. Keep them closed the entire time until the lights go back off. But as opposed to going into a tanning booth or into the sun, that's different. That those rays are going to penetrate deeper, and you do need goggles for that. So it's different for narrowband UVB.
Thank you.
Is there a difference in staging and prognosis for folliculotropic MF versus just regular MF?
There is no difference in staging at the present time. Prognosis is a bit of a dilemma. If you look at old literature, there is a difference in prognosis, but that may be because the entity wasn't recognized properly and perhaps wasn't treated. to approach cells that are deeper into the skin. There's also one paper circulating, I have my own problems with it, but I'll tell you that it exists, that talks about good folliculotropic and bad folliculotropic mycosis fungoides. It basically has to do with the depth of invasion of the cells. It doesn't make sense to me, that paper, but it's widely quoted by dermatologists, and some people are trying to get their pathologists to gauge on the biopsy how deep the infiltrate goes so that they can utilize the data from that paper more fully in treating their patients.
I think one of the things that becomes obvious is with the folliculotropic, the narrow band typically is much less effective because it doesn't get down into the hair follicles where a lot of the tumor cells are. So one of the most effective tools we have for treating early stage mycosis fungoides doesn't work so well for the folliculotropic. So there's this perception that the standard stuff doesn't work, therefore it is more aggressive. But a lot of the other treatments that do get that deep respond equally well. So, overall, we do struggle more because a lot of the topical stuff that we do, skin-based therapy, doesn't work as well. But a lot of the other treatments work equally well if they are able to get down that far.
This is another question about reading pathology reports. Why are they looking for clonality?
So we think of cancer as a runaway clone, meaning one cell has gained the ability to continue to grow without without listening to the normal signal that tells it to stop. So that one cell keeps growing and growing and eventually gets to a size or a mass or gets to be detectable. So if we can identify some marker that shows that all the cells in that biopsy came from one original cell, that is in many respects considered a malignancy. That has to be qualified, but there are other pre-malignant stages. An example like that would be LYP is not kind of considered a cancer, but not really a cancer. It is a clonal abnormality. They can show there's a T-cell clone, but it doesn't behave like most people's definitions. So it becomes a little bit of semantics. The other concern is that sometimes when you do those clonal assays, and it's mostly by the T-cell gene rearrangement, is that in inflammation you can have a small population of reactive cells. So it doesn't have the ability to grow indefinitely and all that kind of stuff, but still shows up as being positive on that test. So clonality is not diagnostic of, it's supportive of a diagnosis of cancer, but it is not diagnostic of because other things can give you that same positive result and not be a cancer.
Do we have another question?
I'll ask the first one. I think that I've heard this weekend that some people sometimes people with 1A may have a patch and they just let it go for a while and maybe wait until I don't know what to treat it. That hasn't been what my doctors have wanted to do, and so sometimes I wonder do different doctors have different opinions of when things need to get treated or how long they... Okay, so I'm seeing nodding heads. Okay, can you tell me more about that?
It is not clear for early stage disease that early treatment or treatment of the disease changes the overall big picture, how long people live. Certainly, treating when you have disease that's earlier, it's a little bit easier to get back under control, less symptoms, but doesn't change the big picture. So with that in mind, there are some practitioners who say if it really isn't bothering you, it's not that itchy, it's not cosmetically an issue, you're not sitting there dwelling on it all the time. Why put something on there that may cause maybe a little harm, thinning of the skin, steroids, or things like that? Why do that if it's not really bothering you? We can just watch it if it does get to be symptomatic, or it looks like it's getting to be spreading or something, we want to get better control, let's treat it at that time. So much more conservative. But others would say, well, if you wait until it gets worse, then we'll have to treat a little more aggressively to get it back under control, and you'll have more side effects if we have to treat it more aggressively, but let's just kind of keep on top of it, and it extends into this maintenance idea too. You know, should you do maintenance when you really don't have a lot of disease? And it also is a mixed picture. Some people do think that it's helpful. Others say, no, we really don't know if it really does extend it that much, or I put you at risk for all these other things and the cost and all that other stuff. So there is different opinions about the optimal way of managing this disease.
I want to expand on it a little bit. We don't know that not treating it doesn't affect people's outcome, because people that go to an academic center and become part of the data for a paper don't go there and not be treated. So we know that what the outcome is for people that are treated with certain stages, but actually no one's ever done a study to see what happens if you don't get treated. So it's an unknown. So I don't want to leave you with the impression that we know that you don't have to be treated. We really don't know the answer. Nobody's ever done that study where they just watch somebody.
It's my understanding that in the dermapathology arena, that there are different specialties within the dermapathology. And there's like the general dermapathologist, and then we got your dermapathologist, who are the ones that we need our stuff looked at. But when our dermapathologist came to talk to us, she talked about the clone hunters. And she wasn't a clone hunter, but she assured me there were clone hunters out there, usually based at the institutions. And so I was like, well, that's cool. So I go down to Stanford, and they take about 4 or 5 different biopsies, and they go, we're clone hunting today. Could you please tell me what the heck that means? And why do I care? I know I have this god-awful disease. Beats the heck out of me. Damn clone. I don't care if you're hunting for it.
Well, sometimes somebody might be doing biopsies with the idea of learning more about the disease, and they might do things like next-gen sequencing or other things that are more in the experimental mode to learn more. That might be one way to interpret that. Otherwise, I'm not sure.
Yeah, I'm not exactly sure what they mean by clone hunting. We'll sometimes do 2 biopsies or more at disparate places to see if the same clone shows up in all those places, which is more convincing argument that this is a malignancy rather than local inflammation. But I don't think that's what they're referring to, so I'm not sure what they mean.
So you think they're looking within like 4 biopsies they took that day?
Yeah, so that's the strategy. If it's the same clone in multiple places or the same clone over multiple times, it has to be done at the same lab. Then it more strongly argues that this is a clonal malignancy and not some weird inflammatory skin disorder.
Hi. What's the difference between the PUVA bat and the PUVA pill in terms of effectiveness?
I don't think we know the answer, because PUVA bath hasn't been used as much in this country as the UK. They use it much more frequently, Israel, some other places, though there are some practitioners that use PUVA baths in the US. I've never seen a paper that looks at them side by side to give you an answer.
Hi. What's the state of knowledge as to whether there's a genetic component to MF?
There's a few papers in small countries like Israel where they know every patient that's been diagnosed that has looked at certain families that appear to have too many members that have mycosis fungoides, but they're clearly in the minority, and that's true for all lymphomas, pretty much. While there are some families that appear to have too many lymphoproliferative disorders in the family, there's no known reason for that. It could be environmental, it could be genetic. We really haven't been able to understand why that might be. And in every kind of lymphoma, they represent the vast minority, not even 10% of patients.
Do we have another question?
My question is about like sunscreen, because they said the sun obviously can help, but when you're wearing sunscreen, then the sun doesn't help you, correct? The sunscreen blocks.
That's correct.
Just like your clothes, right? So, we always laugh about where mycosis fungoides is, right? But it's where the sun doesn't shine, usually. Like, people's behinds and women around their breasts. So your clothes act like a sunscreen, too. That's kind of why it forms in those places, probably.
So, as the dermatologist will tell you, we don't typically recommend sun exposure, mostly not because it doesn't work, it's because of the associated risk for premature skin aging and melanomas and other skin cancers. So that's, so using the sunscreen is not to try to make your mycosis fungoides not respond, it's just that we're worried about all the other bad stuff with sun exposure.
My question is a little off the wall, maybe, but 20-some years ago, I had Hodgkin's disease, and when I was treated with chemotherapy, which was pretty nasty, I used some visualization techniques to kind of make me feel powerful while that was happening. Now, I can kind of picture what's going on in my body with the PUVA treatments, but I'd like to be able to visualize something when I'm shooting up with interferon. And I have no idea what that stuff is doing. I'd like to be able to picture that and give myself a little power while I'm making those injections. Can either of you help me visualize what's happening? I told you it was a little off the wall.
It's really a tough one because nobody knows how it works. So there's a bunch of suppositions how interferon works, but truly we don't really understand it. So one way, so you could pick one and focus on it. I mean, one way is it probably works in concert with the immune system. Another thing is that it creates the production of cytokines, some of which probably kill cells. How else could it work? Directly by killing the cell.
Think of it as a way to arm and boost your fighters. Think of it as a way that the enemy is the tumor cells, and this is a way to arm and boost and empower the effector cells to fight that tumor. So instead of going in there naked, they have shields, they have armor that can kill the tumor cells, and so maybe that is a good way. But it's thought to potentially, like Dr. Brown said, is thought to enhance the immune system to fight the malignancy, to kill those cutaneous T-cell lymphoma cells.
Does anybody else have some thoughts? more creative than us?
Yes.
Okay. Yesterday we had a breakout session for the early stage people with a dermatologist, and we talked about frequency of blood testing. And I know that people have different opinions, so I'd like to hear what you all think for people both with and without burdens of disease.
So part of it depends obviously on what the disease is doing. The other part also is what treatment is being used. So if you're doing narrowband UVB, we don't expect a lot of systemic injury or concerns about doing that kind of stuff, so the need for monitoring goes down. If you're doing methotrexate, there is a concern about developing some liver toxicity and cirrhosis, so you do need routine blood evaluation. If you have minimal disease and it's not changing and it's behaving kind of status quo, you don't need a lot of blood testing. If you have disease that is progressing and you're moving to new therapies, or then you need to do more. Targetin is one that you need to do a lot because of the two known side effects of the thyroid production and the elevated lipids. So you need to do that almost every week, or initially even sometimes more than that, to make sure that those side effects are not going away. So a lot of it depends on what the disease state is, whether it's changing, and what kinds of treatment you're using to get that disease under control.
Were you talking about somebody that's stable in the group? And if they should get blood drawn periodically just for the heck?
That was one of the comments.
Because that's often a question.
Yeah.
Should I have blood done once a year? Or, often I get a question like that. I don't draw people's blood on a routine basis that have early stage disease unless, as you said, something is changing or they're on a therapy that requires blood monitoring. Did we give it the same answer or a different answer? Are you totally confused or? Okay, good.
Not always the case.
Hello.
Yes.
Wonder if there is a geographical expression of this particular disease, whether near the equator, away from the equator. Any studies?
Yeah, I'm not sure. Yeah, I mean, there's two components in that. One is ethnicity that associated with geography. We do know that this disease tends to affect African Americans more than Europeans, more than Asians. Other thing that we sometimes get is areas of expertise. So because of the diagnosis rate goes up and people who know what to look for and how to look for it. Whether there's actually a geographic component to this, it gets to be a little bit harder to know because it's a rare disease. So how much of it is just geography versus the population versus the expertise, sorting that out can be very difficult.
Thank you.
Just a question. For us that are doing light treatment, I've been doing it for 3 years now. And I was told by my dermatologist, when you go on vacation, so I'm going to go on a vacation here for 2 or 3 weeks from now. Do you have any advice what I can do while I'm on vacation to help, he told me to go out in the sun, but just for short periods of time, just to help keep the skin, get UV rays.
The same kind of thing. I mean, we don't usually recommend routine sun exposure because of the side effects of sun exposure. However, we do need some vitamin D. I mean, sun exposure itself is not bad per se. Overdoing sun exposure is bad. Getting sunburns is bad. But if you can't get to your PUVA box or your narrowband and you're going to a nice tropical place, which is where you should go at this time of year, going out and using that as a substitute, just don't overdo it, don't get sunburned, if you've been doing a lot, you'll have a little bit of a base tan, so you can get some exposure without significantly increasing risk of skin injury or skin cancers.
Could you help me understand a little bit about itching? If I have 2 small lesions and they've been treated with radiation, why do I still itch all over?
Itch is a very complex abnormality. As you probably all compare notes, some people have a lot of itching, some have very little itching to no itching. It is a nerve process, so we use a lot of things that affect the nerves. The trouble when it's localized like this is that it's hard to do something local for that particular area. Obviously, things that in the skin can affect that is if if there's, especially if it's been radiated, if it's dry and tends to be flaky and stuff like that, keeping it well moisturized will help lessen that nerve irritation and itch. But more than that, it becomes pretty hard to do something localized. I don't know of anything particular.
Well, so if we're talking about a local area, when I was walking in, somebody mentioned, somebody suggested hot water. I would say not a good idea, but cold water will work, cool will work. And that's kind of the basis of things like Sarna lotion that has eucalyptus in it, is to create a different sensation on the skin. And the brain is kind of fickle, right? So if you present it with a different sensation, it'll forget about the itching for a while, it'll move on to whatever. And that's, in a sense, probably why things like itching and pain are worse at night for people, because there's not as much stimulation for the brain to be paying attention to. I think that sometimes when somebody has total body itching and there isn't a lot of lesions to explain that, the other thing that might be done is to look for other causes. There's a whole list that dermatologists have of things that cause itching, going all the way from thyroid disease to other lymphomas. And you might go through kind of an abbreviated evaluation just to make sure there's not something else going on.
If it is severe enough, there are people who have used capsaicin. So it's the pepper, the substance P and peppers, and you basically go through a period of where you deplete those pain receptors of their neurotransmitters, and so it stops sending those signals. But you do have to go through a period of where it kind of burns, and then until it's depleted. And then if you stop using it, it'll accumulate and you have to go through it again when we put it on. But once you get it there, some people have found that it does cut down if it's a small enough area, and then you can get past that initial period.
I think I probably was the one in the phototherapy group that talked about heated wet wraps. And I no longer live with the disease, thankfully. I've got a cure via stem cell transplant 8 years ago. But I had excessive, chronic, miserable, debilitating itch for about a year. I mean, just where I couldn't do anything, outside of my home, because I was itching so much. So I called Dr. Madeline Duvik because we had lived in Texas before we moved to Colorado. So she was my dermatologist that I saw often. And I just said, I can't live like this anymore, and the gabapentin's not working, and the steroid cream's not working. What can I do? And she actually recommended, she said, go on my website. I want you to start doing these heated wet wraps. And so she told me to put the triamcinolone cream on, not heavily, but moderately, all over and I had scissory, so I just put it everywhere, because I was itching everywhere except for my teeth. So I put it everywhere, and I did put the plastic on the couch, and then the really hot towels underneath my body and on top of my body, and then wrap myself up in a cocoon. So that did work well.
I would call it something different, because I think when you call it a hot wraps, it's a little misleading. Really what you're doing is steroid wraps. Okay. And that really does help. So what you're doing is you're creating a situation where the steroids will get absorbed more by heating up the skin and by occluding it, by wrapping it. So you're right, you heated it up, but it wasn't the heat as much as what the heat does to help your steroids work a little bit better. And that's a known thing that is recommended to people who have irritated skin.
So when you have the combination,
it's the combination that's key. Yeah.
Some people use the sauna suits.
Yeah.
So don't take hot showers, but doing
Yeah,
that
yeah,
probably
yeah.
works for a lot of people. That's
Yeah,
correct.
correct. You can use this Saran, which will really try to get it in. Some people, just so you don't have to wrap up, will use a sauna suit as another way to try to get that increased penetration there. A couple of other systemic things that are being looked at is naloxone. I think that got mentioned yesterday, and aprepitant. There's two things that they're trying to see if that working at a systemic level to help with the itch. The trouble is getting those drugs approved or reimbursed. If you get a prescription for it, most places won't cover it for those indications.
If you've used topical steroids for a long time to where you've had side effects of thinning in skin and other issues, but you still need to use them on occasion, what do you consider the safest way to use them? Like a week on, a week off, 2 weeks on, 2 weeks off? Is there a safer way to use them long term?
So it partly depends on the potency of the steroids that you're using. Higher potency steroids, you need more time off or shorter duration of treatment. Also, it depends on the skin type. So some skin types are able to tolerate a lot more steroids than others. So this is where the dermatologist hopefully will give you good guidance. Typically, we like when people are off, they get at least a week off. That seems to help the skin recover. But again, it depends on how potent, how healthy the skin is and the skin type.
Do we have another question?
Let me, I know this session was also kind of set up to talk about some clinical trials and what's coming down the pipeline and things like that. Just to give you, I mean, there's a surprising number of different ways that investigators, including Dr. Pinter-Brown and myself, are trying to figure out how do we do better with this disease. And part of it, and a lot of this becomes gained by doing what we call clinical trials. Susan gave a very nice talk about drug development, on how complex this all is. But just to give you a flavor of some of the approaches that are being looked at, I thought I'd just give you some of the clinical trials that are available, may be available, not all of them are available at this time. One of the main types of ways to look at and how to treat this disease is to see what drugs work in other types of diseases that are similar to this. So drugs that are already FDA approved for treatment of lymphoma. Example of that would be a drug called lenalidomide. It's an immunomodulatory drug, FDA approved for treatment of multiple myeloma, also being used in follicular lymphoma. It has not been well studied in this disease, and they're using this either by itself or in combination with some study drugs that are not already FDA approved, such as looking at it with monoclonal antibodies, using it with checkpoint inhibitors. So that is a drug that, again, is already FDA approved, has a long track record now, and is now being looked at to see if it has activity in this disease and maybe in combination. Similarly, you've heard a bit about these things, and that is how do we try to manipulate the immune system so it now can recognize the cancer cells. The thought is that cancer cells somehow hide from the immune system. We know that the immune system is important for surveillance of cancer because if your immune system is down because of infections, HIV, because of drugs, organ transplants, that we see more of these kinds of cancers, including lymphoma. We also have found that there are molecules on these tumor cells that tell the immune cells to leave it alone. And these are oftentimes called checkpoint molecules, PD-1. And so there are some antibodies that block that signal, so now the immune system can now see the tumor cells and fight those tumor cells like they would fight infections and things like that. So these drugs, there are several out on the market that are already FDA approved for a whole variety of different cancers. The biggest claim is, Jimmy Carter and his metastatic melanoma to the brain got treated with one of those and it went away. So it is being looked at, and there's some promising early information of a small series of patients been treated with this, and it looks like it may have some good activity in this disease. So either the FDA approved ones, or there are 2 or 3 similar drugs that are in the pipeline to see if they can also have activity. And then using that kind of approach and combining with other things that may help the immune system work better, so something to stimulate that, such as adding it with an immune stimulator or trying to use interferon or things along those lines. There are some other ways that we're trying to get tumor cells to shut down, and that is interfering with the signaling pathways of these tumor cells. So in the B cell side of things, we know that certain B cell lymphomas get signals from the outside to tell it to grow. This is called the B cell antigen receptor. If you interfere or block that signal, the cell doesn't actually get the signal to grow and actually starts dying. The first one to do that was something called a Burton's tyrosine kinase. and it has been FDA approved for treatment of CLL and mantle cell lymphoma. In the same pathway, or a similar pathway, there's another molecule, signaling pathway, it's called a PI3 kinase. And they may be able to, and we know that that is also important in B-cell lymphomas, and it may be important in T-cell lymphomas. And so there is an FDA-approved drug that inhibits PI3 kinase for the peripheral T-cell lymphoma, and looking to see, does it really have activity in the cutaneous T-cell lymphomas? So that is a clinical trial looking at that. We've heard a little bit about a very novel way, this small inhibitory RNA trial that also it would be the first indication for this particular approach. So looking along those. So there are a whole number of studies that are looking at drugs that are already FDA approved for treatment of other diseases and whether or not it would be active in this. There are some drugs that are in very early stage studies. So we have one that is looking at a molecule that kind of tells the cells that tells the scavenger system that the cells are old and should be getting rid of. It's, in the literature, that's called the "don't eat me" signal. And so, if you block that signal, the clearance and the scavenger systems clear that from the body. It's a molecule called CD47. And so there are two drugs that are targeting that particular molecule to see if that might work. And so that's in phase 2 for the one and phase 1 in the other. And then we have a whole number of different studies where it's a broad, it's a more general approach. Let's see in the general area of lymphoma, does it have any activity? And then if that includes this particular type of lymphoma. And that's how they sometimes will, look at a broad range of different diseases and see where the activity is, and then they'll move on to develop it for that particular disease.
Let's give Dr. Okada and Dr. Pinter-Brown a round of applause. Okay. I didn't know if you wanted to make a final comment. Okay.